So I'm going to start on a topic that is kind of, I think, educational for us. Most of you know this stuff. At the end of the presentation, I'm going to really need your participation because I think it's a very thorny issue that we run into, and I don't know of any real good answers for this clinical setting. So I'm going to rely on you. So my topic is really to talk about posterior circulation strokes. I think as time is going on with the advent of TPA for strokes, with more interventions for strokes, that we are really have focused heavily on anterior circulation strokes. So the IH scale is geared towards that. The Cincinnati scale done in EMS, all of those things really are geared toward more of an anterior stroke circulation, which we're more familiar with. And unfortunately, the posterior stroke syndromes are more difficult to diagnose, have much more vague presentations, and are, I think, if most of us would say, are somewhat of a thorny issue because they're not easy to pick up, and yet people progress to significant morbidity and mortality if not picked up early on. So there's Dizzy, my daughter surfing. I don't know if she was dizzy or not, but she sure as heck is going down with that, right? So here's two cases. My partner Mike did a good job with cases, but I'm going to do these two, and at the end we'll talk about their resolution. 50-year-old male physician, sudden onset of nausea and vomiting and spinning sensation. His neuro exam was good. He was unable to ambulate because he was so vertiginous. He had a history of hypertension. I actually saw this guy. He's one of the colleagues at St. Anne's in Westerville. This is the other one. I stole this one from Dr. Weinstock, but it's a good case. 51-year-old female, 2 weeks of acute vestibular syndrome, much worse the day of presentation, diabetic, taking oral agents. She was ambulatory, and she had some positional vertigo. My problem statement, as Ed would like me to do, is that acute vestibular syndrome is associated with vertigo, nausea, vomiting, gait disturbances, head motion intolerance, and nystagmus. Seen a lot in our ERs, 150,000 patients in one study. Some observational studies say probably at least 25% of those people probably have a posterior stroke syndrome, which is a scary thought, I think, for most of us as we think about this. The history is really important in these folks. There are three real processes with dizziness that are of our concern. And again, I'm not going to gloss over this. Most of you have been in the ER for many years. I'm not going to go into the nuances of dizzy versus lightheaded, but let's say you truly have a dizzy patient. It's got vertiginous, spinning sensations. These are the three kind of processes that you should be addressing with that patient, which are acute vestibular neuritis, BPPV, and then your cerebellar stroke. And you want to separate these into isolated, which would be peripheral, which would be the first two syndromes on the previous slide, or the third one, which is going to be, of course, the central stroke situation. And we really want to improve this diagnosis, and it's not easy to do. Did I go the right way? So vestibular neuritis, gradually onset. Usually you've had a cold or something in the last week or so. Duration's usually hours. But again, I think according, we should note, HPI of the gradual or sudden onset of this syndrome is really important. Paroxysmal, positional vertigo, again, the word paroxysmal is important. That should be spasms of 20, 30 seconds of dizziness, lightheadedness, and those kinds of symptoms. Often this one is positional, and again, it's associated with the otolithic semicircular canal situation. And I think a lot of the people in my department, and particularly our mid-levels, tend to do the Dix-Hall-Pike maneuver on all their dizzy patients, but it's really only helpful in this setting. And then there's the Epley maneuver to reposition that otolith, which often will relieve their symptoms if this is indeed what they've got. Physical exam, this is important to differentiate from the central cerebellar stroke syndrome. And of course, anybody dizzy with physical findings of neurological nature, you guys are going to get what you need done and probably with them. And so for this audience, it's probably not as useful, but I thought we'd run through it. So any central etiology findings, any neuro findings, the 5 Ds of diplopia, dysarthria, dysphagia, dysphonia, and dysmetria, which is another word for cerebellar signs of finger nose testing off, or heel shin testing. And then any long track findings of sensory changes in the body, et cetera, would be useful to really get concerned about a dizzy patient. And this is a weird one, but usually some people bring this up. You should have this as in the differential as well, but Meniere's usually has got some mild hearing sensation loss and tinnitus. So our plan, we've had a couple cases that have fallen out at our place. They have not bounced back to us, but bounced forward to other institutions in Columbus. Obviously, we've got several hospitals there where patients would come in, as the two cases that I presented earlier. They go home, they got better with their Anavert and their Phenergan, they go home, and then 2 days later, they've now developed different symptoms and progress and come either back to us or somewhere else. And that's, of course, these are the folks that have got a stroke now going on their cerebellum, which may have been there initially or not. For our purposes, what we're going to do to try and improve this setting for us clinically, we're going to be looking at historical elements, patients over 50 with vertiginous diagnosis, labyrinthitis, those kinds of things. We're going to look at the historical documentation of the vertigo, onset, duration. We're going to look at those physical exams, and then we're going to establish a macro in our Dragon voice-activated system, which we use significantly for these kinds of efforts in our department to try and address all the elements we think need to be present for these folks. CAT scan is useless in these folks unless you think it's a hemorrhage. Okay? The CT has too much artifact low in the skull to be able to demonstrate any kind of infarct in the cerebellar and brainstem areas. MRI is the MRI is the imaging of choice. Of course, with the throughput stuff and all of that, it's a little more difficult to get those done. The MRI for us takes probably 2 hours to get it done and interpreted. It's the imaging modality of choice for this setting if you think you've certainly got a cerebellar stroke. So here's the thing I want to talk about. A lot of these people, I think, that come in with dizziness as a sudden onset and have probably a prodrome or a TIA kind of pattern for cerebellar strokes. And all they have, though, is dizziness and vomiting. We see it very commonly, and my problem is, and our problem is trying to figure out which of those patients we need to proceed to MRI with. The risk factors for stroke in the anterior circulation are the same as the posterior circulation, so hypertension, diabetes, cholesterol, all of those things increase your vascular risk. And they often have very vague symptoms. They can get up and walk around. We all tend to think that the cerebellar stroke folks can't walk very well, and that is indeed true, not all of the time. So, case number one, friend of ours in Columbus, a physician. I admitted him that day. I couldn't get him to stop vomiting. His exam was pretty normal, but he wouldn't stop vomiting. This was probably 12 years ago. He was admitted, had an MRI that was positive for cerebellar stroke. He has persistent vertigo to this day. Okay? He was lucky. Case number two, from another institution in Columbus, was discharged, returned 2 days later with unilateral signs and symptoms, ended up having cerebellar stroke, got edema from that stroke, herniated, and died. So these are the kinds of cases that scare me. This one scares me to death because we've seen this, and we see it, I think, a fair amount of time.